comes by Nobel, it will sell you for about 23,500 rupees. If you go to Jalandhar Surgical, they will sell you for about 2,300 rupees, okay, I think 5,000 rupees. But what it does is flexible like this. There's a hinge joint here and you can align it according to the arch. Maloguide has a characteristic of parallel laser markings which are separated by 7 to 10 mm. Fact. And this is the same thing I told you. Distal to canine eminence, I will mark my anterior wall of maxillary sinus. This is most important step in the first category. So what happens is, once I've marked and I've placed, so the distal implants are placed at nearly about 30 degrees or 45 degrees at the most. How does the maloguide function? They say that if you bisect a rectangle, what is the angle you will get? If I bisect 90-degree angle, so that's how they place. So when you use a maloguide, you will take the entry point here and the entry point here. So you make it bisect, this will automatically enter at 45 degrees. By the time you will end up osteotomy, you will be around 40 degrees. That is how the usage of maloguide is. So it will tell you a clinical way to enter at the implant site. Right? Because it's very difficult for the eye to really enter at 30 degrees, 40, 35. It's going to be a good guide if you use it like this. Okay? You got my help? That's how. So when you have to enter on the distal part, you have to keep it along the ridge or from the palatal to buccal. Slightly palatal to buccal. Two reasons for it. You keep it along the ridge because then the access hole will be in the back and not on the buccal. If you go from buccal to palatal, the access hole will be on the buccal side. Buccal side cheek, you will not be able to tighten this screw. Okay, so you either keep it along the ridge or slightly palatal to buccal, because what happens when you go from palatal to buccal, this is going to be a cortical bone, thicker bone. Remember, the buccal alveolar bone is more prone to resorption. So you have to engage this thick palatal bone here and you will engage a cortical bone at the base. And this implant stability will be much higher because it's going to be bicortical engagement along the anterior wall of maxillary sinus. So that is why you keep it along the axis, along the marked axis or slightly palatal. If you go from buccal, you will always have a problem. In the front teeth also you go from palatal to buccal like this forward, so that my screw comes on the palatal side. If I go along the axis of the tooth, the way my teeth are placed, then my screw access hole will come buccal, which is unaesthetic. So remember, it either has to be from palatal to buccal or straight down, like this or like this, not like this. So you can control the exit point of this thing. In the mandible, same, if you use the maloguide, the first marking you have to do is the mental foramen exit. You take a 5mm loop and you mark that area of danger zone. So whenever you get patient with CBCT, I always ask my radiologist to find this anterior loop of mental nerve. Okay? Because I don't want to injure these nerve endings that will lead to paresthesia lifelong on the angle of the mouth. Also, there is sometimes an offshoot of the mental nerve which goes up to the middle thigh. That supplies the lower gum area of the near the central incisor. That also becomes numb. So that loop also I am looking at. In the 30% of patients will have that loop also. So I don't want to injure those. So that's how your 5 degree is marked. Then again same angle, 45 degrees, you bisect that angle and you place the implants. Again in the front ones, you have to go straight down vertical or from lingual to palatal. Remember, lingual to palatal, because the access openings have to be on the inner side, not on the buccal side. If you go along the axis of the tooth, then also the resorption. So cortex on the angle of the implant is you have to determine as simple. So if you go straight, you're going to be like this. If you go along the axis, you're going to expose the lingual area. This bone is the weakest. So we're going to have failure of the implant. Also, we have a lingual plexus. So there is a high chance of bleeding. mostly straight or from lingual to buccal. Don't go this direction. Clear? Okay? So simple modification you do. If you don't have a Malo guide, what you can do is the guide pin that you have. What you need to do is just this one guide pin, 2 millimeter of hole. Now this and this becomes 90 degree and you bisect that angle to become 45 degree. If you don't have, why does this help? Reach both the sides. Let's say a tooth, patient loses the tooth here more earlier than compared to this one. The sinus levels is going to be at different levels. So your Malo guide will not work sometimes because they are not bilaterally symmetrical. So those areas, then I simply use a guide pin. You can make a 2 millimeter hole, attach, and then you can bifurcate this angle and you will reach 45 degree. The actually angle is to check 45 degree. Some people don't achieve that angle. They normally go straight. So when you go straight, the AP spread reduces. Remember, you have to go as angulated as possible by 45 to 50 degrees because you want to increase your AP spread. If you go straight, it's more like parallel implants. Got it? Clear? Everything's okay? Good. Pre-surgical prosthetic planning. It is very important to have a pre-surgical plan. You need to hide transition zones. I don't want to show my zone when I'm smiling. I don't want to show that transition zone. It will provide restorative space. I need to have more restorative space when I'm making a hybrid prosthesis. Remember, 15 to 18 millimeters. Sorry. Improves emergence profile and it has more hygienic contours that we can see. The minimum space restorative required is basically 15 to 18 millimeters. Remember, for a hybrid prosthesis. That's how we mark. So you need three highest transition zone. So in a patient like this, what happened was this was about 12 millimeters. Okay, and we reduced another 4 millimeter to get the right emergence profile. Got it? Because this was the high transition zone. Clear? Questions? So you can predetermine by the denture that what kind of prosthesis that you going to plan to make and how much bone condition, bone preparation is required. ये सब आप plan कर सकते हो पहले. So you will end up into the same result simply. Clear? Questions? So let's see simple cases. That is not important. Something like this, 4 implants, blah blah blah. Again the impression, the trial, and this was the initial, temporary, final. You can see. Okay? Mid prosthesis with this thing, not castable here. Similar case here. Bad teeth, almost gone. We removed. Now when you remove, there is going to be a lot of tissues, bad tissues. You need to operate and smoothen the bone, clean the bone area. Because if the residual, these things remain, there is going to be a problem with this thing. More important, these are different implants. Temporization. Final prosthetics. So when you see the journey from there to there, medium out. Okay? Simple things. We will do all of them. Now this is a case that I was trying to tell you what happens if the prosthesis fractures. But this was lucky we fractured the prosthesis after 3 months. Now that's the Jalandhar guide. Jalandhar surgical sells this guide. It's got degrees of 17, 30 and 45, everything. Now the guide has everything marked. Okay, they come for 2,000 rupees. If you want to buy, you can always purchase these things. But now I've stopped because I can visually see my angles very well. So that's how the implants, these are the, sometimes the company speak for, sometimes they speak for him also. That's the 4 implants. That's the temporary, and that was the temporary denture that was given immediately on the same day, and this happened. Luckily, that is what I was asking. What happens that if it breaks? Okay, this happened after 3 months. This is the most common complication that you're going to follow. The fracture of the prosthesis. Okay, if it happens on the 25th day, try to repair it intraorally. Don't push the implants out. Okay, most common complication because we didn't reinforce the denture. Anyway, that's the after about 4 months healing, the process is, now remember you have to take impressions by a dual tray method. I'll show you in the laboratory that we fabricate one tray which is actually screwed onto the implants, and there is another wax rim that is used to take the impressions. By registrations. So once the trial, that was the trial denture that is made, remember in a full arch cases you do a reverse engineering. Okay? Now after the trial setup you make the framework. Why? You cannot, because the position of the teeth is static. Now the teeth have been fixed in a position. Now according to the teeth position I can change my framework. I have to keep my framework in or out. If I make the framework first and then do a trial setup, it's going to be bad because the teeth might come out or go back in. So it's reverse engineering. Always do the trial setup first and then followed by the framework designs. Okay? That was the trial framework. That is the metal try-in that we do it. Finally, we had to do a PFM. It was coming to be FP2. That was the final prosthesis that was made. It's a chrome cobalt, milled titanium with PFM. Actually, simple as that. That was the prosthesis that came. And finally, we could deliver something like this. Okay? This is a very common issue in multi-units. Reason? Because when we are selecting and doing a surgery, the tissue is way higher. But with the time, the biological will settle. What is the tissue, average normal tissue thickness? टिश्यू थिकनेस कितनी होती है? मेरे मसूड़े का थिकनेस कितना होता है? How do you classify thin tissue type, medium tissue type, thick tissue types? How do you really classify them? Okay, the average Indian population male tissue is about 0.6 to 1.3 mm thickness. That is, the thick tissue type is 1.3, the thin is 0.6. The average Indian population will have 0.96 of thickness. All them actually thin tissue biotypes will recede because of the continuous pressure at these areas. So that is why the reason when you are looking at high aesthetic zones in FP1, FP2, I am not using multi-units in the front teeth because the recession will happen. Okay? So final prosthesis, screw retain, and so if you really see, that is the pre-op and that is the post-op that we can manage with the same patient. Another case of maxillary arch, simple case. Here we did something like intraoral welding and we extracted same impression, verification, suturing. The prosthesis was made by welding. Now this is not done intraoral, remember. What I did was, I took the impression and then I welded this component within bar, outside on the model. It will help me two purposes. It formed a framework, stiff, good framework. Also I could verify my impressions with it. So when I took this framework and tried in the mouth, it would seat in the same position. Okay? So impression verification as well as a solid framework, that is. This is a temporary prosthesis, lasted for almost 2.5 years, and the final prosthesis was in fact made like that. Okay? That's a build. Alright, right? So let's do the laboratory steps. Now this is a very important part. Most of the people will actually get confused, but I'll tell you the how do you really do the laboratory steps. So let's say it's done by my resident, not by me, but that's okay. Just to show you what. 4 implants placed, we took an impression. This is in mouth, right? Status. Impression copings attached. That is what I showed you in the video. Then took the impressions, attached the analogs, and I got the model. Simple. That is part is clear. Now what I do is I make a trial jig. It becomes with a castable one. So trial jig is attached. And I seat in the mouth and it doesn't seat. Okay? So what I do is, I'll cut that open and check this and this will seat. So I cut that open and I reseat and now it seats. Now the problem is, this is the new form. Now I have 3 options to do. People will straight away cast this, which is not correct. What I do, there one option is I have to take a new impression because this thing should seat. Now the problem with this procedure is it might not be correct. My trial jig might not sit in the new impression. Right or wrong? Because it didn't seat in the last, it might not seat in the new impression as well. First. Second, I do a cast modification. That means I cut my cast and adapt to the new trial jig and relock. Very difficult to orient the cast, split the cast, reorient in two pieces. Not seat very well. The third impression is to do something called, you take the long impression screws and go through them and take a pickup impression of this. Pickup impression with the trial jig. Long impression screws. Clear? ऊपर से निकला? निकल गया? ऊपर से? नहीं निकला? आ गया समझ में? आ गया ना? Remember, these are two pieces. They can separate out. Just use this screw and lock it because the trial jig abutment screw and the head of this is the same. You attach the analogs and the new model is poured. Now I find I'll get more confused. Pattern raising, I tried pattern raising, you joined it, it still has a little shrinkage. Now I picked up the impression, okay. But still I feel my milling will not seat passively. One of them will be tight. So what I check is a stone jig. Now I take my impression post and make a jig around it with a stone, die stone. Okay? And then I reseat this in mouth. This pattern stone jig is actually made on the new impression. So that I want to be sure that this is passive. If it is active, when I am tightening, the stone will break. So it will tell me that it is passive or active. Right or wrong? Right? Confused हो गया? ये ऊपर से नीचे है. So I take impression, take trial jig, jig knot doesn't seat. Okay, jig is not seating. I split the jig, take a new impression with the jig, long impression screws. Now my jig is fitting on the model for sure, but I think some problem might happen. Okay, so I make another stone jig. I want to verify my new impression, but not by the old method. I want to verify my new impression with the new method. So two verifications, so that everything is perfect. So I make a stone jig and seat back. If my stone jig fits perfectly, one is my impression is verified and I know it is passive. How to check passivity? I tighten my screws. When I tighten the screws completely, the stone doesn't break. I'm happy. If the stone breaks, that means there is some problem. Right or wrong? Because stone will not be flexible as pattern resin. They will all break. Okay? So stone jig, that's the next thing. Now bite registration is the next level of bite. That's the impression that we had. You take a single, this thing, you attach, you take a bite and you do a trial setup. This is very difficult because every time I have to open, reduce backs, open it. So now to change that pattern, what I'll do is I'll use a twin base plate method. So I'll attach one base plate on the model, the second above it. So this is the reverse side. So this stays fixed, this is I can reduce backs. And then I take the bite like this. Got it? Right or wrong? So it's called a twin base plate method. That's how it does. Because every time I open, I am engineering the tissues. I don't want to do that. So cut back, once my bite is done, I'll first do the try-in. Okay? First do the try-in, then proceed with the pattern resin. And this was the final prosthesis that was milled according to the pattern. Okay? Finally, a PFM prosthesis was made like this, and the delivery. Got it? So it's a reverse engineering. So, if I start that I'll give you teeth after the healing, it will take me 3 months to finish. Why? Because appointment 1 impression verification, jaw relation record, teeth setting trial, framework trial, second jaw relation, bridge trial, and finally. My lab takes at least 7 to 10 days for one trial. So you can imagine how much time I'm going to spend. Can there be a method to do it fast? Can we do it fast? Right or wrong? Ajit? Yes. We can do it fast. It's called fast tracking. What do? You can do it in 3 visits also, but only thing is you have to spend a lot of time and a lot of money. Okay? It's called CAD-CAM prosthetic. The basic 3 requirements: I can do impressions, I can take a bridge trial and prosthesis delivery without even recording the bite, try-ins, anything. I can do that fast tracking. How to do it? It has 3 requirements basically. The temporization should be ideal. I am not changing the occlusal vertical dimension. I am not changing the vertical lingual dimension. I am not changing any dimension. That means my facing is same. I am not changing the vertical dimension. I am not changing anything. My temporization has to be ideal. Second, it has to be only a CAD-CAM prosthesis. I am not doing a casting. If I am doing a casting, there is going to be casting errors, casting shrinkage. So I am not doing a casting. It's a CAD-CAM prosthetics. And third one is can be only a screw retained prosthetics. Okay? So what happens is I take the long impression screws, open up the abutment screws and attach like this. And then I take a pickup impression. Okay? And when I take a pickup impression, I attach analogs and pour the model. Now the model is ready. You will have the pour model with a lower impression. You can take bite, you can articulate. But at this point of time, I have all the information I have to duplicate. The problem is the patient wants the temporaries back. He said, I will not go without the temporary teeth because temporary teeth are now attached to the model. Right or wrong? If I send this model, every information is there. I took a check bite, recorded the lower model, articulation is good. Reason, I took a simple impression using this temporary only. Okay, which worked as a trial jig, it worked at a vertical dimension, it worked at everything. Right? But I cannot send them without temporary. So what I do is I take a cut back, I take a silicon index of this, what is going to be my teeth position, what is the jaw relation and everything. They just have to make a prosthesis and finished. Let's see a quick case. What they do is, like the case went in, we made the first temporaries placing the implants. I remade the temporaries after 4 months. Remade the temporaries because I wanted the ideal positions, and this was the final prosthetics. Similar CAD-CAM, PFM, finished. This tomorrow, too much of work. Let's switch. कोई सवाल? Okay, the apartment selection becomes a very, I was told that you have a problem with apartments, right? This is the company whose implants you use. इसी के डाले? that's the mandatory slide to be shown. That's okay. Anyway, amazing time today. It's a beautiful time in dentistry. The diameter of the lens are from narrow or short to almost 60 millimeters to zygoma. You can do prosthetics similar on teeth, similar on implants. You can use zirconia, you can use zirconia hair. Material is titanium, PEEK and zirconia. Degree of customization is amazing. You can have standardized and you can fully customize your prosthesis. I can do all of them. Excuse me. Something is in the air. You have implants at tissue level, bone level, removable or fixed completely. You have a 2-stage protocol, or you can have immediate loading. Amazing time of implantology. From the time I started, the second stage I always used to pray to God the implant integrates. Now everything integrates. Thanks to the surface materials, thanks to the design, everything will. If you do simple surgeries, everything will integrate. Not bad. Common location and common size and what diameters normally to be used are this position that you should really be considerate about. So centrals are thinner because they are more smart, but it can vary from patient to patient. It's actually company based driven. So as you go for the molars, you can go with it. But today in my practice, I only use 3 implant sizes width. One 3.0 for the lower anteriors or the upper laterals. 3.5 for the upper and the premolars, and 4 or 4.5 for the molars. I never go beyond the 4.5. People will ask me, what is this, sir? For immediate also? I said yes. The reason is that if I drill a hole in a wall and hang a clock on it, anyway, so if I tell you, if you drill a hole in a wall and you put a nail and you put a clock on it, the weight of the clock is borne by the wall or by the nail? By the weight of the clock is borne by the wall or the nail? सारे सिफारिशी हो गया? या मैंने एक दीवार में कील गाड़ी और उस पर घड़ी डाल दी, अब वजन कौन उठा रहा, दीवार या कील? कौन उठा रहा वजन? अरे कितने लोग कील बोल रहे हैं और कितने लोग दीवार बोलते हैं? एक आदमी दीवार बोलता है, बाकी सब कील बोलते हैं. Weight is borne by what? I am standing on this. My weight is borne by what? On the ground or this? Who is bearing my weight? This podium or the ground? Anji? Who is bearing my weight? Anji? Podium or ground? तो दीवार में कील डाले तो वजन कौन उठा रहा है? कील या दीवार? है? कौन उठाता है वजन? कील उठाएगी, दीवार उठाएगा? दीवार आ गई, कील वाले गायब हो गए. हैं? अभी भी कंफ्यूजन है. चलो यार, you can't take one of the two choices. You can't make in life. Whether it is the wall or the keel, कौन सा उठाएगा वजन यार? हैं? Wall or the screw? Which one will take the load? हैं? Wall. How many say wall? Only 1, 2, 3, 4, 5, 6, 7, 8. How many takes the screw will take the load? कील कौन कौन बन रहा है? बाकियों को क्या है? वो खुद उठाए क्या वजन? बाकियों को इतनी अकल नहीं, कौन उठाएगा? Say it, I can't really take it. You can't make one of the two decisions. It's the wall or the screw which will take the load. The wall takes the load, not the screw. If I'm standing there, the ground is taking the load, not the podium. So the bigger the hole I make, the weaker the bone becomes. So the more I drill the diameter, the bone will become weaker and it will not take the load. Bone is a rare commodity, so I am not drilling anymore. दिमाग ऊपर से फ्री में नहीं मिलता, चलाना पड़ता है. So that is why I am not using bigger diameter implants anymore. Clear? You're all going to become implantologists. I'm going to have sleepless nights. Anyway, so few critical factors that you have to really see. There has to be 1.5 millimeter from the adjacent teeth minimum. And the two inter-implant distance should be minimum 3 millimeters. Why? Why do you need this 3 millimeters? अरे क्यों चाहिए ये डिस्टेंस 1.5 मिलीमीटर का? How did we reach this figure of 1.5 millimeters? Why do you need it? Bone? Bone diagram होती है? कौन सी bone बन रही? You need minimum 1.5 millimeters for two things. One, you need for papilla. Around, if you want to maintain that papilla, the papillary infusion, it has to be minimum 1.5 thickness of bone that I need for some capillary movement of the blood. That's why I need 1.5 millimeters away from it. Okay? To maintain papilla and to maintain blood transfusion in that area. Clear? ये figures ऐसे नहीं आए, रात को उठ के नहीं आए थे figures. Okay? So that's the implant. How deep? That becomes an issue. How deep? From the next cemento-enamel junction of the next tooth, I need 4 millimeters up because I need to create a good emergence profile. Next cemento-enamel junction, from here I need at least 4 millimeters up or 3 millimeters. If I have a narrow implant, then I have to go 4. If I'm using a broader implant, then 3. Okay? 1.5, 1.5. What? How much distance between the buccal bone? Minimum about 1.8 or 2. The 2 is very good. But 1.5 also works. So 1.8 is minimum to be required. Okay? Now, when you do a crown or bridge, what is the minimum height of the abutment? You need at least 4 millimeters for cement retention. So if you don't have 4 millimeters height of the abutment, you will always go for a screw retained prosthesis. Got it? So if it's the minimum interocclusal distance that I need from the base of the implant and the occlusal table is about 8 millimeters, where 2 millimeters will be emergence profile, 4 millimeters or 5 millimeter retention, and about 1.5 millimeters for the crown. So that distance I am looking at about 8 mm from the position of the implant till the crown. That is minimum required point for cement retained prosthetics. Anything less there, I am going screw retained. Clear? Okay, samajh? So how do you choose? That's most important. So abutments, types and selection. This is the most common confusion, right? Healing abutments. Now healing abutments will have a diameter, will have a gingival height. That is here, not from here to there. Remember, you have a curvature which is a taper that starts from here till above is parallel body. It is the gingival height is within this area. So when you see a gingival height, this is 3, then it could be 2, it could be 1. Normally 1, 2, 3 and 4. Don't combine this to this. So when you ask for a gingival height 2, you are talking about this distance, not from here to here. Okay? This height minimum would be 1.5 to 2, the above height. Minimum 1.5 to 2, this is the height. So gingival height is 1, 2, 3, that is how you manage, not this height. So check for the complete height and the gingival height. There are two separate factors while choosing. So when you have posteriors, you will have, when you place implants in the anterior region, they place deeper. So you need higher gingival heights and thinner. When you put in molars, the gingival heights, the implant is placed equicrestal or subcrestal, you will require less of gingival height because of the opposite dentation also. Clear? So choice has to be very clear where you are using. So it comes in 1, 2, 3 and 4 and 5. But that height is only the lower border, not the complete height. First thing. So when you have a standard, this is called a dual abutment. Back up here. So standard. Now when you say a dual standard abutment, you will always find that this has an emergence gingival height which will be 1.5, 2.5, 3.5, 4.5, 5.5, 6.5. Gingival heights can vary because that will determine how deep is your implant. The prosthetic height is 5.5 fixed. They come in different diameters, 5.5, 4.5, 6.5. Even 3.5 they don't make. Koreans only make 3 times. 4 mm. So when the technician trims this black line, what distance is it? If it's less than 4 millimeters, it is not cement retained anymore, screw retained. Clear? This height is marked. So this is 5.5. Got it? You can have gingival heights of 1, 1.5, then 5, 3.5, 4.5 and 5.5. And you can have width of 4.5, 5.5, 6.5. That's Korean systems, most of them. So you must know what are you asking for. पहले पता तो होना चाहिए क्या? Okay, the 3 dimension. Gingival height, the width of the abutment and the length of the abutment. 3 factors. Clear? This is standard cement retained. Other ones are milling abutments. They only come with less height because they mill and make the margin. So they only come with 1.5 and 2.5 gingival height. The length is actually 12 millimeters. आप इसे trim करते हैं. Angle also is the same. The length is 10.5. It comes with an angle 1.5, 2.5, 3.5, 4.5. The gingival height is 1.5. They can vary till 5.5. Okay? This is 15 degrees. And they come with 25. The length here is 10.5 only. Here it is 12. They are all milling abutments. You understand milling? They will mill them. They will grind them in the off. And they will change the angle according to the prosthesis. Remember, we cannot change this emergence profile. ये नीचे का emergence है ना, ये हम इसे change नहीं कर सकते. हम इसकी height काट सकते हैं. पर इसका जो emergence profile है, तो they come standard emergence. They come with 4.5 and 5.5 millimeter diameters. So we can never change the emergence profile. Custom abutments, UCLA, उसकी fixed होती है castable. पर अगर आप प्राइम मिल करते हो, मिलिंग करके बनाते हो, उसमें आप इमर्जेंस प्रोफाइल चेंज कर सकते हो. Got it? So you cannot change the emergence profile. These are standard UCLA. What is UCLA? They have a collar height of 1 mm only. Standard होता है सबके अंदर 1 mm, which I don't like. They should be in multiple heights, but people in India import only one. And this is a plastic sleeve. This is only for screw retained prosthesis, and they do a wax up. I'll show you the case. कैसे wax up करते हैं, बनाते हैं, screw करके casting करते हैं. The base is chrome cobalt, and then you use a chrome cobalt, there's a nickel chrome on it, so that to cast. The only problem with UCLA is what? Implant is titanium. This is chrome cobalt. Two dissimilar metals. That is why the pre-mill blocks are coming, because those are of titanium straight away. What is happening is two different metals. Two different metal leads to what? Electric current. What happens with the current? Bone loss, oxidation. कैसे बनाते हैं बैटरी? भूल गए जब? क्या होता है बैटरी में? एनोड कैथोड क्या होता है? उसके अंदर क्या डालते हैं? एसिड कौन सा होता है? I think you should all go back to 10th standard and study physics. Because half of the things that I know today is because of physics and chemistry. Right? So the height is 12 millimeters. You can change according to the wax pattern and finish. Temporary cylinders can be of two types again. They can be metal temporary cylinders, or they can be plastic. They are peak. So in anterior region, when your aesthetic demands are high, you can use a peak temporarily. In the posterior region, you can use plastic, the metal titanium cylinders. They are screw retained. Okay? The multi-units you've already seen, the straight multi-units. There are screw retained abutments, there are multi-unit straight, and then you have seen the angled ones that are there. These सारी abutments हैं. So if you use the type of abutment, one piece, you can have single piece cement retained. It's called a combi abutment. Something like dual abutment with a single piece. आगे anteriors के लिए चाहिए होती है. Combi abutment. These are all dual abutments, mean there are two pieces. One is the abutment, one is the screw. These are cement retained. Dual milling abutment, you can mill them, but you cannot change the emergence profile. You can mill them according to this thing. You can mill them and change the gingival contour. Emergence profile remains the same, the critical contour you can mill them. So as to make the custom abutments. Something like pre-mills. These are angled screw retained. They can have X, non-X. They can be long, short. Okay? Then you have the hex and the non-hex castable abutment. That's called UCLA. Okay? You have the temporary ones, which can be in plastic, which can be in titanium, and you have the metal casting, which is the UCLA. These are the separate charge for the multi-units. So multi-units have straight, you have 15 degrees and you can have 30 degrees. Both hexed and non-hexed. Hexed and non-hexed. Okay? And then you will have the casting cylinder on top of it. You will have a temporary cylinder on top of it. And this is also, this is metal temporary, this is plastic temporary. Screw retained. That's all the inventory you will ever find. That's all the inventory you will ever find. Okay? So commonly used abutments are like something like dual abutments. The milling, they mill in the lab. The direct, that means UCLA, screw retained, which is multi-units. Also you can have overdentures, something like locators and O-rings. So now, single units, these are, you don't need them, ball and these are okay. This is basically a locator, ball ring. This one you will not. Custom abutment. Now custom abutments are the pre-mill. They can mill that portion and they can make it according to the shape. But the ones that are bigger, now the pre-mill is thicker than the milling abutment. They are more thicker blocks. Because when you have to custom made molar, you need to specify the gingival finish lines. In the other ones, these ones, the gingival lines are circular. The tissue is not circular. आपका जो टिश्यू होता है वो सर्कुलर नहीं होता है. So these are milling units, but they are circular. Okay, we do not have customized emergence profiles. But on the other hand, if you use a pre-mill blank, you can make these custom. So the emergence profile can be customized as well. So the difference between the two, then you can customize this. The margin finish. Scan abutment is nothing, you don't have to worry about it. So standard abutments, if you really see what the diagram shows, they're going to have a circular margin all around. But if you have a custom abutment, I can change my abutment according to the critical and the subcritical contour. The difference, something like this, I have shown in the X-ray, both of them are scanned. Okay, these are scan bodies. So once they are scanned, I used a standard abutment where this is the impression, this is the standard abutment with a preformed emergence profile. This is where I changed and made a customized abutment. Although I will receive the same results, but this is a crown to be done there. But this is just to show the difference will not be much. Only thing is sometimes we need to make a good emergence profile. That is the time that I need a custom abutment. This is a standard abutment. Here the margin will be round, here the margin will be according to the gingival margin. So the difference, if you see this one, the margin is prefixed and they fix the crown just to show. This one, the margin was finished. It is basically from a pre-milled blank, and then this one will have a better emergence profile anything. So when you have to have a good emergence profile, get a custom abutment spray. Okay? Just to show in the case, we did that, just to show. So when you have a custom abutment, I can mark the contour. This is customized abutment. I can mark where I want the gingival margin. So there is a critical contour which supports the crevicular gingiva, means the gingiva that is supported by critical contour. This is the subcritical contour. So when I want to support the margin there, that is what I am looking at. Okay? Now there is another concept called tie or base hybrid. These are the ones that are with the new age abutment. They are same. They come with various gingival heights, remember, and they have a stable margin. Here, but the PFM is bonded, something like a dual abutment. The one that I told you, the most of the Korean will make a dual abutment. These are the European system. They call it tie base. So all the top brands will call it tie base because this is actually made in titanium. The other abutments that I had shown you earlier, these ones are either into chrome cobalt and not purely titanium, but some companies now shifted to titanium completely. Okay? Earlier they used to be in chrome cobalt or stainless steel. That is what I realized. So this is the tie base. Now what is tie base? This comes in various gingival heights. This particular size is of Britain. So don't have to worry about the implant system. And you can use the tie base and you can fix full arch zirconias. They can be hexed. They can be non-hexed, means there is no hex there. So when you use a full arch case, non-hexed. Single unit, hexed. Okay? So they can be used basically screw retained and custom abutments for cement retained. Means you can design the abutments on it or they can be screw retained. This is most important. You need to calibrate the distance from here where the crown. If the crown is too big made, this will debond because the crown is actually cemented on the tie base. And the weakest link becomes, this is what I was trying to tell you. The if you have a small tie base, the weakest link is the cement. This is the most common mistake people do. You have to see the height of the abutment as compared to the mesial distance. Height of the restoration. If the height is too much, the bond strength will weaken. And before you realize, the rotation of the abutment is happening is not because of the implant connection. This is because of the cement breakage. Okay? This is the stupa structure is actually glued onto the tie base. This is what I am showing. It is glued. The weakest link is the glue. Remember. Also, you cannot alter your prosthetics after that. So you can make the tie base, you can make a zirconia coping, and you can do Emax crowns on it. You can do tie base, non-hex, and you can attach all the zirconia framework onto it and screw it onto it. So there are multiple uses to be really tie base. So the only advantage, they are geared for digital protocol. They are ready for the digital protocol. So digital diaries actually pick up tie base straight away. Okay? Not custom, not pre-mills, nothing. They pick up the tie base completely. All the exocard is actually full with tie bases today. This is most important. They mill the superstructure and glue it to the tie base. This is the standard protocol for everyone. Allows sufficient bulk, and it can be used for all types of restorative designs. So this is a design which can be used for individual or for the full arches, but digital part. Also, if you see, there are micro grooves. You see this? There are micro grooves on it to increase the retention with the cement. That's all it does. Okay? They are digital ready tie bases. The disadvantage, the resistance from can be an issue. Debonding, most common problem. Full arch, the debond one of the tie base, the problem happens because now it has not, it is going to be on the rest of this thing. Trials are difficult. Once you have glued and you fix the crown and have adjusted the occlusion, I cannot reglaze it. I cannot send it to furnace. I have to polish now across this. That's one. And definitive bonding, जो bonding होती है उसका excess cement अगर आप बाहर निकाल लोगे, but definitive bonding we still don't have it. We don't have the materials. They actually are just mechanically locking. All the metal primers do not work on tie bases as well as the zirconia. There is no bonding as such between two different metals. They are all fake things. They will tell you we have a metal primer. If you prime the metal, will prime the zirconia, nothing. It is only mechanical lock. Okay? But since it is digital dentistry, the space is less than 25 microns, and we just need to finish that. Clear? Some कुछ confusion? So tie base is for the digital. If you are going for the regular, you want a castable UCLA. If you are going for digital, customized abutments, then go for the pre-mill block. They will mill the abutment according to your choice for single crowns. Tie base can also be used for single, but my recommendation is tie base is mostly for the full arch prosthetics, digital. So you must know where to use what. सस्ता कौन सा पड़ेगा सबसे ज्यादा? कास्टेबल वाला. Okay? 90% of cases can be fixed up with the dual abutments that I showed you. The UCLA is like this. What they do is you take a UCLA, they will build up wax around it, cast this thing, and they will make a customized cement retained abutment. Customized for the front, they can also make a customized screw retained in the back. These are custom. Because these are plastic steel, the base is chrome cobalt. Custom. So you can define the margin as when you want the emergence profile, but this part, that is a standard. This one is standard. From here to where I can, but sub critical contour is standard. That is why it is only 1 mm. Okay? Rest, you can make the emergence profile accordingly. Okay? You need to support this changing one. That's called the emergence profile. So what do you do? Take impressions. You send it to lab, soft tissue contour. They will make the UCLA abutment, wax pattern, cast. Okay? They will do the casting finish and then they will make a single crown on it to deliver. Old case. Simple case, old cases, actually socket shield was there, but even extraction, you left the shield, but I'll show you tomorrow in the case of socket shield. What is socket shield? Non-socket shields? Whenever Cluckman's class 1, when you have the bone which is very thin, you don't want to disturb you don't want to pull out the tooth. You want to leave a shell of tooth there. Okay, you place an implant palatally, make a temporary immediately and let it heal. This is screw retained temporary. Then you need to duplicate the surface, you insert. Okay, attach the crown open and then flow the composites so that my impression coping is ready. Then I take the impression, then I make a customized, this is very old, but UCLA was used. Okay? And finally I could do the UCLA. This is initial, temporary, finals. Okay? But socket shield. So UCLA is very good when you have a limited vertical space. You can make good emergence profile, multi-purpose. You can use for single and multiple teeth. And angulation, you can correct the angulation up till almost 25 degrees, not more than that. People will say, I will correct till 45, nothing will happen. You need angulated screw access channel, they will not correct. Okay? So, up till almost 25 degrees, they can correct. Remember that. So, this is the one that has screw cement retained. This is SCRP. This is the same, this is the dual abutment that I told you. So, the emergence profile is circular, it is not gingival. So, this is the same I case showed you. Okay, remember the case? Use a dual abutment, take a trial, jig trial, you make a tooth and you bond the tooth on this. And you mix the screw retained prosthetics. Okay? That's how in the model, in the mouth, and that is how it will be. See? Great? Remember the cases only now. We extracted, crafted that side. The simplest technique to hold the teeth doesn't grow. Take a wire and bond. It will not supra-erupt. Otherwise, the things supra-erupt. Okay, thick wire. Gauge 16. So that it doesn't supra-erupt. PDS. Buckle side only. This is the right side, must be the left side. Again, open up. Next is the gingival collars. This is the final screw retained zirconias. This is the pre-op. This is the post-op. These are all on standard abutments. Standard abutments. We are not talking about dual abutments. Standard. Okay? Standard abutments. SCRP. Same thing. Non-fracture, bilateral extraction, remove the tooth, save the tooth. Again, just bond it. Implants placed. Gingival collars. Again, the same teeth are used for temporary, just bonding. 1 week later, maybe after 4 months, impressions. There are 2 individual crowns. Provisionals are made for the temporaries. I want to correct my emergence profile. So I'll give them temporaries, screw retained. Then after about 6 weeks, it takes 6 weeks to really heal up impressions. These are standard abutments. I just milled them to change they are circular, not customized. Then make the crowns, and now finally the crowns are in and finished and screw retained. You can have an access hole. Simple case, the premolar is fracturing, remove the premolar, temporary abutment. We can trim the temporary abutment, use what? Protem 4, make screw axis and make a crown, temporary crown. Okay? Then after 4 months, you can take an abutment level impression. It was just taken like that. A screw was made, finished. That's how different stages. It is fractured, the temporary and the final. This is SCRP, where the emergence profile is predetermined. You see this? This emergence profile is fixed. You cannot change that. If you see the changing here, that means it's a custom abutment. Clear? Any questions? Which question? Rehabilitation must create harmony between function and aesthetics. That's more important. Anyway, any more questions? One दो बज गए. सर्जरी कितने बजे? चलो यार सर्जरी क्या करो? Any questions? So abutments, any issues? Because I was told specifically a lot of confusion about abutments. Abutment में कोई issue है? UCL is castable, pre-mill block is milled. Okay? Tie base mostly used for full arches for digital. When you are doing digital dentistry, जो आप रोज करते हो ना यार, मुझे पता है डिजिटल करते हो. डिजिटल करते हैं सारे. Digital tie bases. Okay? You can change the gingival head only. Rest is cemented onto this. And rest of the cement retained are something like SCRP, dual abutments use. Rest straight angle 25 degree, वो सब आप मिल कर दो, ऑफिस उसी को भेजो, वो उसको ट्रिम करेगा और उसमें दांत चिपकाने वाला बनाएगा. All of them are cement retained. Okay? Now since the dentistry is changing towards screw retained, my advice is to use more and more with the access opening. यहाँ पर access hole सही आ जाए. Okay? So you can use more castable UCL, you can use pre-mill, you can change the direction, or you can use SCRP as a dual abutments. So that you can tighten the abutment tomorrow. Again. Questions? Clear हो गया? कौन से लगे इसमें? जो दो फ्रंट वाले हैं, हाँ वो मैं क्या करता हूँ, उसका इमर्जेंस प्रोफाइल बनाना है. तो उन्होंने आपने इंप्रेशन ले लिया. नाउ दे विल पोर द मॉडल एंड यू विल हैव अ silicone gingival mask. Okay, that is smaller because my temporary was not supporting. So now I want to increase that, so I can